Hello, my name is Dr Dima El-Sharkawi and I'm a haematology consultant at the Royal Marsden Private Care. I have a case to discuss with you. I have got a 22-year-old gentleman who presented to your surgery with fevers. Wasn't an obvious cause, has a bit of a sore throat but not much else, and so you've performed some basic bloods. And you can see on the blood test that he has got a mild lymphocytosis. And so I want you to think about the differential for why this patient may have a lymphocytosis. I think I've given you enough time to think about it now. Now, of course, in a 22-year-old with a mild lymphocytosis such as this one, with also a bit of a sore throat, you're going to be thinking about viral infections, potentially EBV infection, glandular fever. It's the right age group. But what happens if I told you that this patient wasn't 22, but he was 82? Then the lymphocytosis and what your most likely cause for the lymphocytosis, I think, in that scenario would change. And given that he's relatively well, apart from the fever, probably what I would be thinking about as the most likely cause in an 82-year-old would be CLL, or chronic lymphoid leukemia. Chronic lymphoid leukemia, or CLL, is the most common leukemia diagnosed in the Western world. So you can see the incidence and the statistics of how frequently it's diagnosed in the UK on the screen now, and these are figures from Cancer Research UK website. So I think the key thing to see here is it's more common in males than females. We've got the traditional blue and pink bars to make it easy for you to see the incidence between the two sexes. But that also, you will see as you look at on the x-axis that this is a disease of the older age group. So the median age at diagnosis is early 70s. So you will see that most frequently patients are diagnosed in their 60s, 70s and 80s. However, we do have a small cohort of younger patients. So we have at the Royal Marsden a few patients in their 30s and even in their 20s who are diagnosed. So obviously that's quite unusual, but it can occur. So most often, by the time we all get older, patients are having blood tests for lots and lots of different reasons. And so most often this is picked up incidentally. So patients have a full blood count as a routine test, and then it happens to be picked up that they have a lymphocytosis. Patients can also present with symptoms, however, and the symptoms are mainly related to the impact of having too many of these lymphocytes on the normal bone marrow function. So patients may present with the symptoms of anemia, so that's shortness of breath on exertion or tiredness. They may present with excessive infections because of the impact of the CLL on the normal immune cells and immune function. Or they may present with thrombocytopenia symptoms, so easy bleeding or bruising. So that's how they might present because of the marrow dysfunction. But some patients with CLL can also have quite enlarged lymph nodes, again as a result of their CLL, and so may present with the symptoms of lymphadenopathy or generalized symptoms such as weight loss or B symptoms, which are night sweats or loss of weight. The B symptoms are much less frequent in CLL than in other lymphoid malignancies, but do sometimes occur. So when a patient has a raised lymphocyte count, the first thing we want to do is to see whether this is actually CLL or something else. So there's certain things that we need to see about the lymphocytes to confirm whether it's CLL. So firstly, that the lymphocytosis is persistent, so that it's not that it's gone up because of an infection, for example, and it's back down to the normal range the next week. So it's persistent. And we want to also see that it's what we call clonal. So how I normally describe this to patients is that your B lymphocytes help fight infections, and they're the more sophisticated part of your immune system. So they target specific infections and all look slightly different from one another, and that's how they can target different infections. Whereas by definition, if a cell has become malignant or cancerous, then those cells all look the same. And the scientific way I explain to patients of saying that is that they are clonal. So we can look at the proteins that are on the surface of the B lymphocytes to see whether these cells are clonal or polyclonal. So we can look to see if the cells are persistent, if the cells are clonal. And then there are other malignant causes of lymphocytosis that aren't just CLL. So for example, we can get certain lymphomas that can present with a raised lymphocyte count in the blood. So we will look at what the cells look like down the microscope and what the pattern of proteins they have on the surface of the cells to help differentiate CLL from other lymphoid malignancies that can affect the blood as well. CLL is what we would consider indolent hematological malignancy that is quite slow growing. We have got lots of new treatments that we can give patients that work very well for CLL. However, none of these treatments are curative. So like other slow-growing indolent lymphoid malignancies, we don't necessarily treat patients as soon as they're diagnosed. Indeed, there are many patients that are diagnosed with CLL that never need treatment for their disease and they're just monitored. So when patients are diagnosed, the first thing we do is try and identify, do they have an indication for treatment? And if they don't, then we will simply monitor them in clinic. If they do, then we will discuss which treatment option to give them at that point. So patients are monitored until at such a point that they need treatment. Often it's related to if they're starting to get low blood counts as a result of their CLL becoming more proliferative and increasing, or because of enlarged lymph nodes that are becoming increasingly symptomatic. And like I said, CLL, our treatments are very good, but they're not curative. And so in many ways, CLL can be considered for a lot of patients like a chronic disease. And sometimes for some patients with CLL, it's not just the malignancy itself that can be problematic, but it's the complications and the indirect complications that can occur or more likely to occur because of the CLL. So we know that the longer someone has CLL for, the more impact it has on the normal immune function. And so for some patients, the CLL itself per se isn't the problem, but they do get a lot of problems with immune dysfunction and recurrent infections as a result of having the disease. And so we often work closely with our immunologists or need to give patients prophylactic antibiotics and sometimes prophylactic immunoglobulins because of the infection complications. We know patients with CLL as well have a slight increased risk of second unrelated malignancies, and so it's always worth having a lower index of suspicion. So for example, skin cancers in patients with CLL are more frequent than in the general population. Our treatments for CLL have changed dramatically even in the past 5 to 10 years. So before that, our mainstay of treatment was chemotherapy or chemotherapy plus antibody therapy. But we've virtually moved away from chemotherapy as treatment for CLL. And now our treatments are more targeted and targeting enzymes that we know are overactive in the CLL cells. And so some of these treatments are tablets, and they may be tablets that patients take for as long as their disease is responding and they're not getting significant side effects from them. So a bit like you prescribe tablets for high blood pressure that patients may be on for many, many years. So now the way of us treating CLL has become in some ways more like that. But that does, of course, mean that whilst they're not getting the side effects and the toxicities associated with chemotherapy, these newer treatments are not without their own potential side effects, and patients may end up coming to you to manage some of these toxicities. So for example, one class of drugs that we give is a class called BTK inhibitors. So they are tablets that inhibit the activity of an enzyme called BTK, that it works in the B cell receptor pathway. So an enzyme that's in the B lymphocytes that is overactive. Now, these are very effective against CLL, but we know that patients are at increased risk of hypertension with BTK inhibitors, and there's a small increased risk as well of atrial fibrillation. And so we often need our primary care physicians to be aware of this, and so that, you know, if patients do develop hypertension, we can work alongside you all to ensure that that is dealt with appropriately. And sometimes we also involve our cardio-oncology colleagues to manage some of these cardiac side effects. So it is worth being aware that our treatments for CLL have changed, but so has the safety profile of the treatments changed as well. So I have given many talks on CLL to lots of different people, and I wanted to end by just talking about some of the questions that we get asked from primary care physicians and sometimes from patients as well in terms of CLL. So one question that we get asked is about whether it should be the hospital that monitors patients with very early stage CLL, or should these patients be discharged back to primary care? And I think it won't surprise you all to learn that there's a lot of variation in the country as to whether patients stay within secondary care or get discharged back to primary care. I think that you need to work very closely with your local referral hospital to develop clear pathways and clear protocols and SOPs if patients are going to be monitored in primary care, partly to give you as HCPs the information that you need on the potential risks and what to look out for in patients with CLL. Importantly, also the risks of infection and what vaccinations we would recommend, and clear guidance if you're going to be monitoring patients as to when to refer patients back into hospital. And there are various local policies that work well across the country, and so you need to work closely with your secondary care team about this. And then the second question we get asked is about prognosis of CLL. And I think this is a harder question to answer because our knowledge and subclassifying patients changes with time as we understand more about the disease and as we're routinely testing for different prognostic factors. But there are lots of different prognostic scores that can help stratify patients into low risk, medium and high risk. And I've got an example here of one of the largest CLL scores. We wouldn't expect primary care physicians to be working this out because it often does involve doing some of the specialized testing. So things that I'm going to just mention to you, like IGHV status, TP53 status, can help stratify patients into a prognostic group. And so, but you will see that actually those with low risk CLL are very unlikely to die from the CLL, and many of them are unlikely to need treatment for their CLL, whereas there are a cohort that are much more likely to need treatment, those high-risk patients, and for those patients with a more aggressive disease, unfortunately, some can succumb to the disease if their disease stops responding to our current therapy. So there is wide variation, but we would be discussing that with the patients in the clinic when they're first diagnosed. Thank you very much for listening.
We hope you found the session informative and useful. If you have any questions about it or want to know more about referring patients into private care at the Royal Marsden, do please contact me. And likewise, any information or feedback on these sessions is always gratefully received. Thank you very much and take care.